In our first session, we had a couple of our superstars. We had Dr. Fiona Webster and Eldon Lowe give us a bit of a taste of the kind of work they do. This time, we're going to have Dave and I give a bit of a taste of what we do as sort of the holders of the grant, so to speak, at this point. And then, as I mentioned, we're going to continue to invite others and tap others to come and do something similar. So I'm going to start, and my goal here for today is, as I say, to give sort of a high-level overview of the kinds of work that I do, the kinds of things that I have done, and where I'm going these days with my work. So I'm going to share my screen. There we are. So I'm going to talk a little bit about sort of my work, quite intentionally trying to do work that crosses sort of traditional academic boundaries. About me, for those who don't know me, my primary appointment is within the School of Physical Therapy. So that means I'm over here at Elborn College, at the corner of Western and Sarnia Roads. I am cross-appointed to Department of Psychiatry with Schulich. I have a couple of very different roles. I've just listed some of the more relevant ones here. So co-director, my role is for Innovative Solutions, which is such an exciting title with kNOw-PAIN. That is a spinal pain rehabilitation research group I'll talk more about here in a couple of slides. Obviously, as I mentioned, co-lead of the kNOw-PAIN initiative. And as you might expect, as many of us do, have associate scientist roles with things like Walton, as well as with Western's Bone and Joint Institute. And the other thing I just want to flag is that I'm a member of an operations committee, and I was a member of the successful team who pitched this idea for the Faculty of Health Sciences Musculoskeletal Innovation Factory. So that's a factory intended to facilitate digital application development, websites, apps, wearables, things like that. It's physically housed over here at Elborn, but it is open to all Faculty of Health Sciences members. For anyone in particular, it's helpful for end of grant KT, for example, if you want to create an interactive tool or toolkit based on a research grant or a project. The Innovation Factory is there to help you move that to implementation. I mentioned I'd talk a little bit more about kNOw-PAIN. I think it's relevant for those who, again, aren't familiar. This is my primary research group. So myself and Alison Rushton, who is also our school director, are the co-directors of kNOw-PAIN. We are an interdisciplinary clinical research group, and we focus on specifically musculoskeletal spinal pain with a rehabilitation focus there. When I say interdisciplinary, we've got a number of people who come from a clinical background, but we've also got people in the fields of artificial intelligence and machine learning. We've got some qualitative researchers. We've got quantitative researchers. We've got over 20 members in kNOw-PAIN. And what we're really quite pleased with is we have a very robust patient partner advisory group that provides a lot of input on the type of work that we do within kNOw-PAIN. They provide research priorities. They vet almost every study that we propose doing within kNOw-PAIN through our advisory group, and that's been a very robust group over the last 2 years. So that's been a great experience for me, and I certainly credit Alison with the development of that. She's championed the patient partner advisory group. One of the key initiatives coming out of kNOw-PAIN that I think could be of relevance to this group is an international registry of people with spinal pain who are seeking rehabilitation. So this is not a surgical registry, importantly. This is a rehabilitation registry. And historically, rehab data has not been captured well in any kind of central format. So the SPINA Rehabilitation Research Registry is an opportunity for people who are experiencing spinal pain to either self-register, and when they do so, they're presented with a survey, quite a few questions related to their pain experiences. They also indicate whether they'd be interested or willing to be contacted for future research. So this could be a real nice opportunity or resource here for those who are seeking participants for research studies. We also have a mechanism whereby if you want to use the SPINA platform itself, which is an approved data collection platform with the necessary privacy and confidentiality mechanisms in place, you can talk to us, you can submit a proposal, and we can in fact build certain questions or surveys into that database, and you can actually have your own sort of separate or sub-study within SPINA. The database itself runs on the mPower platform, which is also housed here at Western. Diane Bryant is runs the mPower platform, and so it's really helpful in that we can in fact, she's actually just down the hallway here at Elborn. We can go down and talk to her if there are requirements or if we need to make revisions to any of the data collection forms. We currently have collection sites running in Canada, and the UK is just about to get off the ground, as well as Australia. And we're also currently working with groups in the Netherlands and Nigeria to implement the SPINA registry as well. And then the other thing we really wanted to do with this was not make it something where people simply put their information or their data in and then are never able to access it again. So really the primary focus of the SPINA from the participant or the patient perspective is that they can use this to track their own health status, their own pain status and functional status and things like that over time. And they can download a PDF of their reports. They can bring that into their rehab visits or even their physician visits. So the intention here is that it's both collecting a source of data for those of us who might want to sort of mine a large database, for example, as a potential source of participants for anyone who's interested in recruiting people with spinal pain, musculoskeletal spinal pain, and for those people who have the pain or who live with the pain, an opportunity is something where they can track their outcomes and use that as a communication tool with providers. So that's the SPINA registry. We so far have only been collecting self-report data with a sort of small handful of clinical data as well when we have clinicians connected with this. However, we were recently, myself and Allison were recently successful in applying to the Bone and Joint Institute's Grand Challenges Fund competition. And what that's going to allow us to do is to start to add some biomarkers into some of the SPINA data so we can supplement the self-report data with some biological data, bloods and saliva, and ideally even imaging markers as time goes on. Our grand vision for this, what we'd really like to do is to take data collection off campus and take it to the people, take it to the communities, in particular communities of people who might not otherwise typically come up to a university campus or even necessarily go into a hospital for data collection. So we're pushing hard for what we're currently sort of familiarly calling the BioBus, which would be something an outfitted sort of mobile data collection unit. And I put this here if anyone should happen to have any ins with I don't know, any automobile dealerships in the city or manufacturers who might be able to help us secure a bus would be very helpful. A couple of other resources, just so people are aware, we've got a number of think tanks and initiatives happening around campus. So the Common Spine Disorders think tank is one of the sort of exemplar think tanks with the Bone and Joint Institute that I co-lead with Allison. Obviously, we have just mentioned the pain think tank. Of course, we've got the kNOw-PAIN IDI, which we are all here for today. I've also been leading an outcome measures research group, and that will become germane here in just a slide or two. We've got a social justice and trauma-informed healthcare in physical therapy working group that's outside of Western. That's very exciting. I have a chance to be involved with a microbiome and mental health group that's centered at Lawson, and a new muscle map consortium that's centered at the University of Sydney, which is intended to be a sort of international registry or data bank of muscle imaging, which that's about the extent of my knowledge on muscle imaging. I'm more involved with it from the measurement side, but really lots of exciting things happening both locally and internationally. I also want to push or promote and let people know about the Master of Clinical Science in Advanced Healthcare Practice and Interprofessional Pain Management. I'm quite pleased and proud of this. This is a degree program that I created. Well, it's a field I created within our degree program. The Masters of Clinical Science degrees are one-year post-professional degrees. They have traditionally only been open to regulated health professionals. So starting in 2025, and the reason I wanted to raise it now is we are loosening those inclusion criteria, the eligibility criteria, such that anyone who has sort of a professional role in the field of pain writ large would be potentially eligible. So that could be health professionals, could be researchers, educators, policymakers, advocates, social service professionals, anyone who would benefit from developing a sort of master's level, we'll say, understanding of the concept of pain. The program itself includes 2 field-based courses, a leadership course, an evidence-based and critical appraisal course. a capstone project, and as well as mentorship. It is truly interprofessional. So in the past, for the first 5 years of running this field, I've had 31 students through that represented 12 different disciplines. And again, this was when it was restricted only to people who were regulated health professionals. And it's been a lot of fun for me to learn with, from, and about people in other fields, definitely outside of physio. So we've had medicine, dentistry, pharmacy. We've had traditional Chinese medicine, acupuncture, naturopathy, massage therapy. It's been really a great opportunity for these students to really learn about how people in different disciplines see the notion of pain differently. And interestingly, we do very much see these concepts of pain quite differently at times. So our next cohorts, we're taking a pause this year because the program is undergoing a revision, but the next inception or the cohort will be incepted in September of 2025. And the application portal should be opening very soon. So for anyone who might know of someone who would be interested in a 1 year, it is a master's level degree program in pain management. This is really the only sort of true interprofessional master's level pain management program in the country right now, that direct them to that website. So that's a little bit about just resources. In the last sort of 5 or 6 minutes, I'll just talk a bit about sort of my own personal interests. So I have, as I mentioned earlier, very intentionally tried to position myself as a transdisciplinary researcher, trying to speak the language across a number of different fields. We've got a couple of definitions of what transdisciplinary research is there. I like the last bullet. That one probably pertains mostly to me: a reflexive, integrative, method-driven scientific principle aiming at the solution or transition of societal problems by differentiating and integrating knowledge from various scientific and societal bodies of knowledge. So in other words, trying to look at these grand wicked problems such as pain or spinal pain from a number of different perspectives, and as many different perspectives as I can. So examples would be some work that I've been involved with in the natural sciences. So you can see things around RNA. I've worked with engineering colleagues to develop new metrics or novel metrics for cervical circumduction, for example, so measuring cervical motion. We did identify a blood panel that might hold potential for identifying people at risk of chronic pain following acute musculoskeletal trauma. That actually went on to be patented by World Discoveries, although that patent has recently lapsed, which was a good thing for me, so I can continue to work on it. It's come back to me, and now it's no longer under patent. So this is some examples of some of the natural science work that I've been involved with or led. On the psychological side, probably where I've become arguably most comfortable for some time. Again, primarily looking at the way that mood and psychological states and thoughts and cognitions affect recovery, or the likelihood of recovery following acute trauma in particular. So I've used motor vehicle collisions as my primary model for trauma for many years, but we've certainly recently have branched out to sort of trauma writ large, and looking at trauma through a number of different lenses. The social sciences piece is where I'd say I'm least comfortable with, but have also been most active in trying to develop my competencies in this over the past several years. Exploring things like intersectional discrimination, experiences there as far as how that might affect pain, what is the association between things like educational attainment and pain outcomes. And I was also privileged to be part of the most recent global burden of diseases study for neck pain. That was out in the Lancet earlier this year. So doing my best to sort of broaden my horizons. Really trying to implement true transdisciplinary research by doing things by, let's say, looking at the biology of a person within their social context. And can we explore interactions between things like blood markers and social determinants of health? I mentioned I've got a bit of a role on a group focused on the microbiota and looking at how the microbiome might influence mental health, and have continued to grow my own competencies through a process of unlearning and relearning around critical gender scholarship and other disability scholarships, and trying my best to understand how those lived experiences influence people's ratings of pain, for example. A big risk for those who are trying to badge themselves as transdisciplinary is that you fall into the trap of trying to become a jack of all trades but a master of none. And so to try and avoid that, and what I've been most focused on, I would say, for over the past 15 years of my career, is really in the idea of clinical measurement, psychometrics, and metrology. You can see there links to 3 different measurement scales that I've published. The very first one, the Traumatic Injury Distress Scale, is a risk and prognostic screening tool that's intended to be implemented with people following any kind of acute MSK trauma, and it seems to be reasonably accurate at predicting the likely recovery outcome a year later. The multidimensional symptom index is a different take on ways of trying to quantify or understand the symptom experiences of people with pain. And the satisfaction and recovery index is my attempt at a sort of personalized, person-centered, importance-weighted health-related satisfaction scale. These are all distributed right now through the scholarship at Western Institutional Repository. That's what those links there are for. If anyone's interested, there's user manuals. A couple of them come with web apps like the Multidimensional Symptom Index. They're all linked there. I'll make sure that people have the slides after this session. And then finally, as I'm wrapping up here, I am trying to I'm in the midst of a prolonged professional evolution. I've come to the idea of critical theory and critical scholarship, what I'd consider late in my career. Trying to better understand questions like, what are the effects on the person and on the interpreter of applying numbers to something as subjective and personal as pain, for example. So actually, I've reached that point of my career where I'm now critically interpreting and critiquing my own work that I've done to this point. This started with a cross-Canada research project I did back in 2017, where I drove coast to coast and engaged with all sorts of people. And really, it became apparent to me that the kinds of measurement tools we were using to understand the pain of another person were limited in a lot of different ways, were potentially even harmful in different ways. And so that really sort of stimulated this evolution. I've since had the great opportunity to work with people, including some people on the line today, to better understand or to think about the way we understand pain differently, the way we measure pain differently, why it is and how it is that the majority of what we call pain evidence has been based on a scale from 0 to 10, and what that means for the ways we understand things like pain, what it means for the ways we intervene. So really trying to critically interrogate that, trying to understand issues related to sort of what it means to be a good practitioner, again, within the broad context of pain management. Most recently had my very first sort of primary authored paper in this field, that was a Merleau-Ponty-esque phenomenological anatomy of the idea of what a neck is. As you can probably pick up, I've done a lot of work in the neck. And so I'm really pleased with how that turned out, but I also very much feel that I'm at the beginning of, despite the past 7 or 8 years to get to this point, the beginning of a professional evolution. And so finally, just wrapping up, I'll just let people know some of the various things that we've got here as far as resources. So right out here outside of my office here in my lab, we have the Vision project running. This is a virtual car crash simulator where we're trying to apply some of the techniques of lab-based research to humans. The radar plot approach to pain phenotyping could be a whole other conversation. But anyway, the idea that we need to look at pain, we need to consider it more widely than a 0 to 10 scale, which I think you've probably picked up by now. And continuing to push other projects forward. I've already mentioned the SPINA registry, and I just want to rehash that again, reminding people that registry exists. And for those who are interested in accessing people with MSK spinal pain, it is there, and there's a process through which you can do that. It can be done through our website, the kNOw-PAIN website at Western, which I will also link to. So that was my whirlwind run through some of the things that I've been doing. Dave, do we want to kick right over to you and then open it up for questions afterwards?
We could take a couple questions now if anyone has them.
Sure. Yeah, we've got a couple minutes.
Or we can do it the other way around, and
yeah, we'll let it sink in. Yeah, we'll let it simmer for a bit. Yeah. All right, Dave, over to you.
All right. Does everyone see my slide and my pointer? Good.
Perfect.
All right, I'm going to do something a little different than what Dave just did. And rather than do an overview of all the types of research in my lab, I'm going to focus on two types of research and two papers that have just come out this year that kind of exemplify those areas of research. So I use neuroimaging in the lab. My focus is cognitive and emotional dimensions of acute and chronic pain. And ultimately, where we're trying to go with this discovery research is looking at biomarkers and improving treatments for chronic pain. So we tend to think in the lab of the pain experience beyond just the sensory component, but also including the cognitive and the affective component. The way that we tend to conceptualize this in the lab is that the experience of pain is really dependent on the interaction between this cognitive and emotional response to pain. So you can imagine, for example, stubbing your toe or doing something that hurts acutely. And so you have lots of sensory input in that case. But it's really the transition to this stage where it's reaching your attention and you're having an emotional response to it that we describe as the pain experience. And so when this is an acute pain, like I just described, we know we have that cognitive and emotional response, but we're also aware that this is going to pass. But you can imagine in a situation where it's now chronic pain and not just acute pain, that your brain's adaptation to responding to pain is going to be much different, as you recognize that this pain is not going to resolve itself. It's something that I have to live with. So I have some good examples of how you can actually experience pain in the absence of this sensory input. Today, it seemed appropriate to see if I could invoke a little bit of pain in the audience with an image like this. And so, of course, this is a bit of a joke, but and it does have sensory input too, because you had the visual response, but the experience that we are all feeling right now is based on the interaction between our cognitive and affective brain circuits. And so that's really what we aim to study. So this is data from a real quick meta-analysis using this website, neurosynth.org. If you have not played around with this website, I recommend doing so. You can enter any kind of term. I put in pain, and it will pull up functional MRI studies that it has in its database that have the keyword that you inputted. So this is 422 fMRI studies that have the keyword pain. Most of those use induced pain by doing something like what we do in the lab, which is applying a thermal stimulus to the arm or the leg to a point that the individual describes it as being painful. And then we see what areas in the brain light up. And you can see a number of different regions, and we can kind of, across many different studies and ways of looking at the neuroimaging, break this down into what we think those individual regions are responsible for, or what dimension of pain they seem to be more associated with. And so we can break it down into the sensory component or the more cognitive or emotional response, for example. So part one of the talk will go over cognitive mechanisms of acute and chronic pain, and the second part of the talk will cover our work on pain biomarkers. So this goes back to my original PhD thesis work, which examined pain and cognition interactions, where we essentially had people in the MR scanner experiencing pain while doing a cognitive task simultaneously. This is the type of result that we get from healthy individuals performing a cognitive task. The cognitive task that we used in this experiment had 4 levels of difficulty or levels of cognitive load. And so what this is a multivariate pattern that shows that with increasing difficulty of the task, you get relatively increased activation of all the red regions, which form a network, sometimes known as the extrinsic mode or task positive network. And you get a suppression of all the areas in blue, which make up what's known as the default mode network. And so these two networks kind of work in concert. When you have high cognitive load, the task positive network is activated and default mode is suppressed. And similarly, when you're sitting at rest, you have high metabolism across the default mode network and relative suppression of the task positive network. So what we first showed was that when participants were experiencing pain even in the absence of performing any cognitive task, we could still recapitulate activity across this task positive network. And that's after removing all the regions that are pain specific. So the regions that come up in a univariate analysis of pain alone. So pain alone can activate this cognitive network. And when participants then experience pain while simultaneously performing the cognitive task, we get further enhancement of activity across this task positive network and further suppression of the default mode network. So this early study in healthy individuals really gave us the hypothesis that patients with chronic pain would be engaging these cognitive networks, but not only when we evoke pain experimentally, but essentially continuously as they're experiencing their spontaneous pain or constantly in a state of pain. So I'm going to skip over those experiments that we did in chronic pain populations, but we looked at chronic low back pain, fibromyalgia, migraine, and others. And this is other groups have looked at osteoarthritis and CRPS, and this seems to be a very consistent finding that patients do in general overactivate cognitive task networks when performing a cognitive task compared to healthy controls. So that fit very well with the hypothesis that we had. One region that consistently came out in this research was the dorsolateral prefrontal cortex, or DLPFC, and particularly the left DLPFC in these earlier studies. So my colleague at University of Toronto, Massimo Aedi, and I wrote a review article on the role of the DLPFC in acute and chronic pain, its connection to various brain networks, and how we might target it in interventions. I did a short sabbatical in Denmark to actually test whether we could use RTMS, or repetitive transcranial magnetic stimulation, of the left DLPFC to reduce acute pain in healthy individuals. And we use this muscle soreness model. This was in collaboration with Siobhan Chabrun, who's the collaborator on a lot of the work that I'm going to show. And we did show that RTMS could reduce the pain intensity experienced in this muscle pain model. And a few other studies, all tend to be pretty small sample and slightly underpowered so far, have shown RTMS has clinical applications too in various chronic pain conditions. So that's shown here. Some of the studies have looked at migraine, and burning mouth syndrome is probably one of the best studies show so far that RTMS of the left DLPFC is effective at reducing clinical pain. But the DLPFC really became a focus of our work for reasons that it fits very well at integrating activity across the extrinsic mode and default mode networks, that it's enhanced in patients and changes with treatment, and that it's involved in descending modulation, or keeping pain out of mind. And this came about in really early neuroimaging studies identifying that same region. We also noted that it was modulated by mindfulness meditation, and a focus of my lab has been on non-pharmacological interventions for chronic pain. This gave us a clue that perhaps using mindfulness meditation can engage the networks that we're interested in and restore some cognitive function in patients and potentially reduce pain. So we ran a fully powered clinical trial of what we called enhanced mindfulness-based stress reduction. So mindfulness-based stress reduction is a standardized protocol, and we enhanced it by extending the dose and also having some migraine-specific training in there, compared to an active control group. And we had imaging outcomes, of course. So we imaged people at baseline prior to randomization and at 2 time points, mid and post-intervention. Essentially, what we found is that patients randomized to the MBSR plus group had a reduced number of headache days and a greater percent response. So the bars here represent the number of responders in each group, and in the MBSR plus we had 52% versus 22% in the this is stress management for headache, or the active control group. And so it really was effective at preventing the number of headache days. We also saw related, what we interpreted as increased cognitive efficiency, whereby doing a cognitive task in the scanner, patients randomized to MBSR plus relative to the SMH group could perform that same task by recruiting fewer cognitive related regions. And so there's more details on that in the paper, and I won't go over it here, but it fit very well with our hypotheses. The specific regions didn't quite work out the way that we had wanted, but in terms of network activation and changes, it fit very well. So this is where I'll get into our current work. So we've, since that discovery, we've been working on kind of narrowing down what are the mechanisms that really relate cognitive processing and pain in the brain. And one region that we have been focusing on is the claustrum. The claustrum is highlighted here, the right in red and the left in blue. It's a very thin subcortical structure that has typically been very difficult to use neuroimaging to detect because it's surrounded by these other gray matter structures, and you get partial volume effects or signal bleeding over from these other regions that make the specific signal from this region hard to detect. My lab has worked out some methods to ensure that we're getting claustrum specific signal. And now we're applying that to different scenarios. Together with Brian Mather at University of Maryland, we came up with this framework of what the claustrum is doing in the brain. So this is based on a lot of literature, mostly in animals, but also supported by some of our human work. That claustrum is involved in initiating the synchronization between distal regions that make up the task positive network. So regions like DLPFC and posterior parietal cortex have to function in synchrony to be able to have that network engaged. And the claustrum takes input from the cingulate cortex and simultaneous output to these regions, synchronizing them at the onset of a cognitive load. So we initially showed that to be true in cognitive task. And my PhD student, who's about to defend in December, who's in my lab that's about to close in Baltimore, Brent Stewart, has run these studies examining claustrum signal related to experimental heat pain. And he showed that claustrum is activated right at the onset of pain, which fits the hypothesis of claustrum activation perfectly, and that pain is a cognitive load. So we see activation of cognitive networks, and we also see claustrum activation right at that onset. In migraine patients, he then looked at cortical activations during a cognitive task, and he identified these two dorsolateral prefrontal cortical areas. So one that fit very well with the area that we had been looking at previously, and that was roughly the target for the RTMS studies, although we moved to right side, not left. And then this PIDL-PFC, which is posterior inferior, which was activated exclusively in the patients and not in the healthy controls. Brent went on to show that this PIDL-PFC is normally activated during pain in both healthy subjects and patients, but is never activated in healthy subjects during cognitive tasks. So a pain-related DLPFC is being recruited during cognitive performance, but only in chronic pain patients. Right, so this PIDL-PFC and right claustrum is activated in both controls and patients. So these are significant activations, but you can see that the level of activation is much higher for both of those regions in patients compared to controls. That's just the time course data showing essentially the same thing. And we went on to do both structural and functional connectivity of this region in the hypothesized circuit that links the claustrum to the PIDL-PFC, and showed that it's through this circuit that PIDL-PFC is being abnormally activated during pain and during cognitive task performance in the patients compared to healthy controls. So we've identified a network that's potentially the result of the aberrant cognitive task activation in chronic pain patients. And it's one that can be potentially targeted either through the cortical connections to the claustrum or directly modulating claustrum. And one of the intriguing things about the claustrum is it's really has really dense 5H2A channels, which are the channels that are responsible for psychedelic effects and psilocybin and other psychedelic drugs. So that's a potential pharmacological target for the claustrum. The second area is pain brain biomarkers. So this is an area that has been growing in interest very recently, coincidentally only, coincided with the NIH HEAL initiative, which really had a strong focus on promoting the use of pain biomarkers. So moving from mechanisms to biomarkers to try to find new potential interventions for chronic pain and reduce the dependency on opioids. So these are just some examples of the papers that came out in that period that were really talking about the potential use of brain-based biomarkers and also their limitations and ethical considerations is something that was added on to that discussion. The reason we're interested in biomarkers, and there's many ways to look at biomarkers, but we're interested in a prospective or predictive biomarker. It can really be summarized in this graph. So this is a study that looks at over 400 participants who had undergone surgery, and it could have been any type of surgery. That a lot of it was thoracic or lumpectomy or any other type of surgery that will often lead to prolonged persistent pain in some patients. And what they did just for this figure is divide patients who had high pain or low pain immediately post-surgery. So they wake up in the recovery room, they get an immediate, give an immediate pain rating, and were classified as either high acute pain or low acute pain. And you can see very clearly in this graph that those who were in that high pain group had pain for a much longer time and recovered much later. They were also more dependent on opioids during that early period and so on. So our best predictor currently of whether you will go on to develop chronic post-operative pain is your pain immediately after surgery. And of course, that's not very useful. What we'd like to know is if you're at risk of developing chronic post-surgical pain prior to going into the surgery. So we wanted to know if we can predict who will end up in each group. So this work has focused on the alpha rhythm and a metric that's measured using EEG called peak alpha frequency. So very briefly, we can apply an EEG cap over the brain, as you see here, and we get a readout of that. This readout can be broken down into its frequency components. So this is looking at between 7 and 13 hertz, or 8 to 13 hertz, which is the alpha frequency band. And we're just identifying the peak frequency for every individual. And so that will vary for every individual from very slow to very fast in some, but usually sitting somewhere around 10. And we have a reliable way of doing that now using automated methods as well. So that's the metric that we're talking about. Very simple to acquire, can use dry electrodes. This is something that could be done in a clinic in 10 minutes. So it's or even faster. It's useful as a clinically translatable biomarker. So the work that really got us started in this area was that peak alpha frequency seemed to be slower in chronic pain patients than healthy individuals. My former student, Andrew Furman, plotted the results of these 3 studies combined. That shows when you look at peak alpha frequency in patients compared to healthy controls, the curve is shifted to the left or to slower frequencies. So chronic pain patients have slower peak alpha frequency. There's a recent meta-analysis that shows this to be quite consistent, but we didn't know at that time point. This is cross-sectional data. So are these people who are prone to developing chronic pain and they've always had slow peak alpha frequency, or is this something that changes with the development of chronic pain? So we tested this using various prolonged pain models. This is the first study that came out, and this is Andrew up here. He's now a research associate and hopefully will be assistant professor in the new year at University of Maryland. So we used a model called the capsaicin heat pain model, where we apply 10% topical capsaicin cream to the arm or leg. That sensitizes the area, and then we can just apply a warm stimulus to it. What would normally be experienced as warm is now experienced as moderately or intensely painful, and we can hold that out for hours without creating further tissue damage. So we recorded peak alpha frequency 45 minutes prior to the participants experiencing any pain. And essentially what we found in this first study was that people with slower peak alpha frequency tended to have higher pain intensity ratings to that model 45 minutes later. And the people with faster had less pain. Of course, you can see there's a decent amount of variability, but we were able to explain quite a bit of the variance there. And if we just do a median split of the fast versus slow peak alpha frequency, if we split based on pain sensitivity, so high pain sensitivity in red and low pain sensitivity in blue, we can see essentially a recapitulation of what we saw in the chronic pain condition of patients being slower. Now it's the high pain sensitive individuals who appear slower. So maybe this is a sensitivity biomarker. Whoops, this is supposed to run by itself. So these are some of the studies that we have subsequently published on the topic, including predicting postoperative pain in lung cancer patients, which was a small study, but supported the idea that we could predict postoperative pain outcomes with this measure. And I like to point this out, that Andrew's work really seemed to be a catalyst in the field. I've got a couple papers to review in my inbox right now on peak alpha frequency and pain from other labs across the world. So this is something that is growing. And I'll end with this, our latest work on this. This is work done by Nahian Chowdhury, who is our postdoc at University of New South Wales in Sydney. and done jointly with Siobhan Chabrun and a group of people at University of Maryland as well. So this was essentially doing initial analytical validation of this biomarker, which included peak alpha frequency, together with the biomarker that Siobhan's group had been working on, which is a TMS-based biomarker of cortical motor excitability. And I won't go into detail on that, but we used on that biomarker, but essentially you can map out the area of brain where you get a muscle response when it's stimulated. And so you get these motor maps. We were using a muscle of nerve growth factor injection into the masseter muscle to produce a model of temporomandibular disorder. And we would get pain diaries that participants filled out twice a day for 30 days following induction of the model. And so we would watch how a person's pain and pain behaviors changed over time following this model. And we would assess our cortical biomarkers at baseline and then at a couple time points early on during the development of pain. We use predictive modeling. The details are set out in the protocol, but also in the paper that's available on medRxiv now, and hopefully will be out soon. And so we divided up a training set of 100 participants and then tested the predictive accuracy of this model on a test set, which the model had never seen, of an additional 50 participants. Essentially, what we showed is that we could train this model to predict with perfect accuracy who was high pain and who was low pain sensitive in that first 100 participants. And when we applied that model to the test set, which again, the model had never seen, it performed with 88% accuracy at predicting the high pain versus the low pain sensitive individuals. And this won't mean anything to you because I didn't give you the background, but here, if you take those predicted high pain and high low pain and divide them up into their peak alpha frequency responses, you again see that leftward shift of the high pain individuals to slower peak alpha frequency. So we didn't tell the training model that slow peak alpha frequency should be associated with higher pain. That was something that it pulled out. So an entirely data-driven method that really supported the use of these metrics as a biomarker. So we think that maybe we're onto something here, that we can actually predict who will end up in each of these high acute pain and low acute pain groups, which would be really important to know for surgeons who are about to recommend surgery to a patient or not. That's the summary, and I'll stop for questions at this point.
Well, that's terrific. Thanks, Dave. In fact, that's awesome. That's got me already thinking of a few things that we probably need to discuss. So I'm watching the time, and I think out of respect for everyone, I'm sure many people probably have, like me, something else to get to in a couple of minutes. This accomplished, I think, what we wanted it to, which was to continue to expose the group to the kinds of work that is happening here on campus. We plan to do another one of these ideally in December, so watch your inbox for that. If you do have questions, I think by now you probably know how to contact either one of us. You can reach out directly or through Felix, who's our sort of primary point person here. But again, a sincere thank you to everyone for joining today. I hope that was helpful, and we can't wait to see what we can do in the field of pain over the coming couple of years. So thanks to everyone. Enjoy the rest of your day.
Thanks, Al.